So cancer prevention, 10 million deaths a year from cancer. That's 1 in 6 individuals worldwide. However, in the UK, 1 in 4 of us will die of cancer. That is 167,000 deaths per year, with approximately 1 in 2 of us over the course of our life developing a cancer, and that excludes non-melanoma skin cancer. So the figure that's often thrown around is that 40% of cancers are preventable. That's a little bit of a sort of crude derivation from the epidemiology. That means if you look at the risk factors that have been associated with cancer and the attributable fractions, so things like smoking, obesity, alcohol, industrial carcinogens, that averaged across all cancers, they represent about 40% of the etiology. But some things we're not very good at measuring in the epidemiology, so we can get an odds ratio for red meat consumption. I don't know if we can get an odds ratio for bad diet. So some of those factors are not well captured within that 40%. Conversely, the 40% assumes that you could get everyone down to a normal weight, which probably, it isn't feasible. So that 40% is both an under and an overestimate of what is modifiable. Clearly, because the incidence of different cancers varies quite dramatically based on socio-demographic characteristics. Some people are much better at cancer prevention themselves than others, whether it's where they live or how they live or what they're exposed to. And I think the other factor just to sort of think about as we open this discussion is we're talking about policy. Policymakers are politicians. Politicians like relatively immediate rewards within the political cycles. Interventions around cancer prevention tend to have quite long lag times before you see effect. It's difficult to attribute the outcomes to that specific intervention. And you don't have grateful individuals who perceive that their cancer has been prevented by being caught early on screening or cured by a magical treatment. So there's probably less advocacy and engagement of patients and patient groups around prevention, and particularly for risk factors that aren't linked to a particular cancer. So those are a few sort of basic themes to set the scene. I'm now going to hand over and introduce each of my panel. So firstly, I have Bethany Shinkins, who is Professor of Health Economics, Diagnosis and Screening at the University of Warwick, and she's worked extensively with NICE and NIHR around generating the economic evidence by which you evaluate the effectiveness of different types of interventions around cancer, including preventative ones. So Bethany, can you give us a bit of an introduction about how we use health economics to balance that focus between where we spend money? Is it treatment? Is it prevention? Is it screening?
Brilliant. Yeah, thanks, Claire, and thank you for the invitation to speak today. So I should start with the usual caveat that everything I say is my own view and not representative of the views of the UK NSC. So health economics, so it can play a crucial role in helping us understand where we should focus research and development efforts, be it cancer prevention, early diagnosis, or improving treatment strategies, by providing a systematic quantitative framework for evaluating the cost effectiveness of different healthcare interventions. So cost effectiveness analyses compare the relative health and cost consequences associated with different interventions. The overarching aim is to make sure that resources are used as efficiently as possible to maximise the health benefits to the population. An additional important consideration is not just the money that we spend on something, but also the resources used. So acknowledging that money can't always solve the issue of heavily constrained resources within the NHS. Health economic analyses can also evaluate the distributional impact of interventions, so help to ensure that resources are allocated in a way that promotes health equity. So all in all, these analyses can really help policymakers and funders make informed decisions about resource allocation, prioritise interventions that offer the greatest benefit for the available resources. So it all sounds great, doesn't it? So we've got these methods. I think you can sense a but coming. Well, the issue is, to do this well, we need really robust data and evidence on the clinical effectiveness and cost implications of these interventions. And this is where it gets tricky when it comes to prevention and early detection interventions. So due to this time lag between the preventative or screening intervention and the observable effects on cancer incidence and mortality, this can often take multiple decades. So it makes it really time and resource consuming to collect this evidence. And often by the time these longer term studies are complete, treatment pathways have changed, technology's moved on and evolved, and hopefully our understanding of cancer biology is developed. And so at the moment we don't have validators, surrogate markers predictive of incidence or mortality, but we know there's lots of work ongoing in this area. So because of these challenges, we have much more evidence for the cost effectiveness of treatment strategies compared to screening and prevention strategies, despite intuitively these often being the more preferred approaches. So a systematic review was conducted by Wynne et al. In 2016. So this was a systematic review of cost utility analyses of prevention, screening and treatment strategies across all cancers. And they found that 71% of cost utility analyses were focused on post-diagnosis interventions, whereas just 17% were focused on screening and 12% focused on primary prevention. So interestingly, when you look at the results of these studies, you look at the actual cost effectiveness results, there's no one cancer control strategy, be it prevention or early detection, which was consistently more cost effective than another. And that may be just due to the biases in the evidence available. But it was basically highly dependent on the cancer, the setting, and the interventions themselves. So in summary, health economic analysis is a really valuable tool for decision makers to make informed choices about where to invest resources in cancer control efforts, research and development. But they are essentially an evidence synthesis tool. So where we're subject to methodological challenges in developing clinical effectiveness evidence, etc., we also face these within cost effectiveness analyses. And that's combined with the issues in estimating costs and quality of life over long periods of time.
Jolly good. Okay, well, I'm sure we're going to come back to various of those themes. I'm now going to introduce Peter Sassini, who is Professor of Cancer Prevention at Queen Mary's University, London, previously at King's and running their clinical trials unit. And he has a wealth of expertise in many aspects of cancer epidemiology, screening, prevention, but in particular, extensive experience around HPV vaccination. So Peter, can you just give us a brief introduction to the successes and limitations of the HPV programme, where that's going and whether there are any other similar paradigms on the horizon?
Thank you. So I'm interested in sort of medicinal prevention, so using medicine. So I'm very lucky to have worked on HPV vaccination. So virtually all cervical cancer and many other cancers are caused by the human papillomavirus. So very common virus, many different types of the virus, over 100 different types. But most of the cancers are caused by two types, and most of the rest by another 7-8 types. And so we now have vaccines that prevent infection with those viruses. The original vaccines, we thought we had to use 3 doses. Now it's pretty clear that 1 dose is enough. It's quite interesting scientifically why that's the case. But the vaccines have to be given before people are exposed to the virus, or before they're exposed enough that they would get infection, because the current vaccines are only prophylactic. We were pretty certain as scientists that having shown that the vaccines prevented infection, and then there were other studies that showed that people didn't develop cervical lesions, that it would work. But it was only a couple of years ago that we actually had evidence that groups who are vaccinated have dramatically reduced risk of cervical cancer. And so it seems to be sort of 80-90% reduction in risk. In the UK, that's in cohorts that were offered the vaccine. So it's not just in terms of the individuals who are vaccinated, which is a great thing about vaccination, that unlike other preventive strategies, even the people who don't participate can benefit because of herd immunity or herd protection, so that if you start getting rid of the virus, then other people who haven't been vaccinated just won't be exposed to the virus. And so it appears that it's working incredibly well. There are very few countries that have the same level of HPV vaccine uptake as the UK does. So in America, it's probably only about 50% uptake rather than 85 90% uptake. But there are now some low-income countries that do have very high vaccine uptake, Rwanda being one, and there are also now both an Indian vaccine and a Chinese vaccine, which, whilst they don't break the patents, are almost identical, and I'm sure will work, and should mean that the price of the vaccine comes down. In England, we've seen that because the vaccine uptake was so high, it was also the case that, for instance, in Tower Hamlets, which has one of the lowest rates for cervical screening in the country, had 90% uptake of the vaccine. So it is possible not only to have a dramatic effect on cancer incidence, but also to reduce health inequalities by having a public health preventive intervention. In terms of other things, there's hepatitis B vaccine, which could be used and would have a big impact on liver cancer in some countries. But unfortunately, the majority of cancers in developed countries are not due to viruses for which we've got vaccines. And so that is only a limited solution. But I think maybe David Crosby will talk about anti-cancer vaccines, which could be used specifically targeting the early steps of cancer development.
For sure, thank you. So next, I'm going to introduce Susan Domchek, who's with us from Philadelphia, where she's a practicing oncologist, but also Bassett Professor of Oncology and lead of multiple research programs and trials. But most relevant to this context, she's been involved in a number of chemo prevention trials, particularly in BRCA carriers. So I thought maybe, Susan, you could just introduce us to a few examples around chemo prevention, and also speak with first-hand experience as to the challenge of setting up chemo prevention trials.
Yes, thank you so much, Claire, for having me. And in my daily practice, I see individuals at high risk for cancer, and also I'm a breast oncologist. And when you look at breast cancer chemo prevention, we often have patients say to us, well, we need a pill to prevent breast cancer. And I'm like, we have 3. And so it's a testament to the amount of work that has been done over the years in these very large randomized trials that are placebo-controlled, investigating tamoxifen, raloxifene, and then aromatase inhibitors, and have shown that these 3 medications significantly decrease the risk for the development of breast cancer. And these studies, again, were done in the UK, they were done in the US, and these medications are commercially available. And I think that Peter may discuss later the availability of the aromatase inhibitors in the UK. So this is really exciting that we have these medications, but in the US, at least, the uptake is actually quite low. So these trials were done, and I mean, the initial NSABP P1 trial was 13,000 women. P2 was 22,000 women. These are enormous trials. They cost a ton of money. And if you get to the end and people still don't take your drug, then we do have to say to ourselves, okay, let's figure this out a little bit better. Let's make sure that what we're developing works. So why don't people take medications? And I've thought a lot about this. And, again, there's a lot of different evidence out there. But I do think that it's in part the fact that people take cholesterol-lowering medications to prevent heart attacks and strokes, but they can see a cholesterol level. So they can see that it works. And we don't have anything like that yet. And so I would postulate that one thing that could really help us in this space is to show people that when they're taking their medications, it's working. In terms of more other ways to think about developing interception or prevention strategies, I'm very interested, and I think we'll talk later about risk stratification to identify those at highest risk. Because if you can identify the people at the highest risk and you have a sense of their yearly risk of cancer, when you power your study, it doesn't potentially have to be 22,000 people. It can be smaller than that. So this idea of risk stratification and targeted risk intervention, I think, is really important. So I'm very interested in BRCA1 and 2 carriers because they have a very consistent yearly risk of developing breast cancer. and whether we can think about novel approaches there. And, there's an ongoing denosumab trial. We have an ongoing vaccine trial. There's the theoretical idea that you could use something like olaparib. So I think there's a lot of work to do, but I think that no matter what, when we're thinking about designing these trials, we have to say to ourselves, is this going to be palatable to our patients? Are they going to take the medications? Because otherwise we spend a lot of money investing in this. And I'll say just a quick word about aspirin, because I don't want to make it all about breast cancer. Aspirin has also been shown to decrease colon cancer risk, but in Lynch syndrome, this is high doses of aspirin. In the women's health study, aspirin didn't seem to do that much. So we also have to think about dose and schedule and things like that when we're investigating these options.
And Peter, do you want to say a couple of words, just because aromatase inhibitors have been in the news in the UK recently?
Yes, if you're using drugs to prevent cancer, you need to have a really low side effect profile, and the drug needs to be pretty cheap. So we're often repurposing other drugs, and so all the drugs that Susan's talked about are repurposed, and they're often off patent. That creates sort of governance issues, and for the first time, the UK has kind of solved the problem of the fact that no company wants to sponsor a drug because they don't have the patent on it. And so the NHS has, for the first time, it took about 2 years to sort out. So on the back of the big clinical trials like P2, IBIS-2, which showed that women who are at high risk of breast cancer or women with DCIS had reduced rates of invasive breast cancer if they took aromatase inhibitors prophylactically. But then they've now said that actually this is a license indication for taking the drug in prevention, and the hope is that it will now be more widely used. But as Susan said, it still has the same side effects and is still not going to be very popular with a lot of women.
So next I want to introduce Rebecca Beacon, who is Associate Professor of Behavioural Medicine at the University of Leeds and focuses in particular on trialling of complex behavioural interventions around diet, obesity and weight management. So Rebecca, can you give us a little introduction and overview how you approach the study design to establish which of the interventions work more or less well to influence these very important, prevalent areas, that everyone is effectively at some level of risk and modification around diet, weight management, and exercise.
Thanks, Claire. Yes, so I think as we all know, over the last few decades or so, we've developed good evidence, mostly from large observational studies, that the type of food we eat, how physically active we are, and our body weight impact our risk of developing certain cancers. And obesity in particular is currently the second most common modifiable cause of cancer after smoking. We don't yet fully understand all of the mechanisms underlying these relationships, and we need to improve the evidence for the impact of positively changing these behaviours and supporting weight loss in those affected by obesity on reducing cancer risk. But we do have some evidence for some of the behavioural approaches that can support people to eat more healthily, exercise more and manage their weight. So to date, this evidence comes predominantly from randomised controlled trials in both the general population and specific populations, so those affected by type 2 diabetes, for example, where we compare a behavioural programme we've developed with Usual Care or compare two programmes. So, for example, over the last few years, there have been several large randomised controlled trials that have demonstrated the potential for total diet replacement programs as part of a behavioural weight management program to support people affected by obesity to lose significant amounts of weight. And in people with diabetes, this approach has also helped some people to achieve remission, which is really promising. One of the other key ways that we try to determine what works more specifically, so that's looking at programs overall, in terms of some of the behavioural strategies that we use within these programs, is through combining data from a number of studies that might have used similar strategies or techniques within their studies to see if overall it looks like programs that contain those techniques work better compared to programs without. And from these studies, for example, we know that giving people information alone about what they should be doing is rarely effective, but that multi-component interventions that use certain behaviour change techniques, such as goal setting and self-monitoring, particularly when these are part of regular behavioural support sessions, can be helpful. Sorry.
No.
I was just going to conclude by saying, however, these interventions don't work all of the time. They're not for everyone. I think we haven't yet found the silver bullet for behaviour change, but there are new approaches that are starting to be used, such as something called the multi-phase optimization strategy, which is to help us try and understand even more the precise bits of our interventions that are working during the development phase. I think that could really help to move the field forward.
Thank you. I'm now going to introduce Kate Hamilton-West, who is Head of Social and Behavioural Research at CRUK and has a background as a research academic in health services sciences and as a clinical psychologist. So she leads CRUK's Social and Behavioural Research team, which is at the interface around commissioning research around behaviour, but also its implementation into policy and practice. So Kate, can you give us a little introduction to operating at that interface and how we develop evidence and influence policymakers around the value of that evidence for all behavioural interventions, not just diet, but maybe alcohol, smoking, other things?
Sure, thanks very much, Claire, and very good to be here today and also to listen to the fascinating points from the speakers that have spoken so far. So I lead the Social and Behavioural Research team at Cancer Research UK. I'm also an academic behavioural scientist by background, specifically in health psychology. And the Social and Behavioural Research team has a very specific role in conducting and commissioning targeted research to address key evidence gaps that are important for informing policy and practice. And this includes work focusing on cancer risk factors such as tobacco, obesity and alcohol. And we also evaluate CRUK activities and initiatives. So, for example, awareness raising campaigns around obesity, which, as Becca mentioned, is the second most important cause of cancer. But from our work, we recognise that it's not as widely recognised by the public perhaps as smoking. So we've had some targeted work to focus on awareness in that area. We also work really closely with other teams across CRUK's Policy Information and Communications Department. So, for example, working with our policy team, we work with our data and evidence teams that are looking at the evidence base to identify where we can have the greatest impact to improve our cancer outcomes. This very collaborative way of working means that we can make sure that we target our work most effectively in ways that are likely to have an impact in terms of improving cancer prevention and all the way across the pathway. So just a few observations in relation to this work. The first is really that developing evidence-based approaches to change behaviour is really important rather than relying on sort of common sense assumptions of the way that people behave, which often are not particularly accurate. People don't always behave in the way that we think they're going to behave. So we do need that evidence base that Becca's described in terms of those randomised controlled trials. But we also need to make sure that people can access interventions that are evidence-based and that they're not designed or delivered in ways that can potentially widen existing inequalities. So if we take smoking cessation, for example, we know that people that use smoking cessation services to quit are more successful in those quit attempts than going it alone. So there's a good evidence base, but uptake of services can be quite low, and it's lower still among those living in more deprived areas. And this is a particular concern because we know that nearly twice as many cancer cases are caused by smoking in England's most deprived areas compared to the least deprived. So this is why we need research that uses evidence from behavioural science, from implementation science, from health services research and from health policy research. So we can look at things like when these interventions are offered, are we reaching a high proportion of the target population? Are we reaching those that are most at risk? If not, why not? What are the barriers to accessing these interventions? are they being implemented effectively by health systems and supported by government policies and funding? So this is where we really need a combination of all of these disciplines to make a difference. The second observation is that behaviour change at an individual level can be constrained or prevented by the environments that we live in and by commercial influences. So, for example, our Tesco trolley trends analysis that we conducted in partnership with the British Heart Foundation and Diabetes UK revealed that people often set out with intentions to buy healthy food, but these intentions can be derailed, for example, by product placements, price promotions, and labelling that can make it quite difficult to determine which foods are healthy or unhealthy. And we've also commissioned research looking at food delivery apps, which revealed similar tactics that are used to drive increased sales. So we do need action from industry and from government as well to enable people to make healthier choices, and just relying on individual level behaviour change is unlikely to be sufficient in the context of these very sort of strong environmental and commercial influences. And of course, we have to think about other aspects of the environment, such as living and working conditions, transport, housing, etc. So when we're thinking about influencing policy, it's not just health policy that's important. We really need health to be embedded across all areas of policy making.
Thank you. There are lots to pick up on there, which we'll come back to. And finally, David Crosby, who is Head of Prevention Early Detection at Cancer Research UK, but also advises the Office for Life Sciences and UK government around the UK's cancer mission. So David, can you speak briefly as to CRUK's approach to prevention research and prioritising sort of focus on basic mechanistic understanding versus behavioural trials and trials of clinical interventions?
Sure, thanks, Claire. So, as you mentioned at the start, the current kind of mantra is that around 40% of cancers are considered preventable, but that's because of, as you alluded to, the risk factors that we know and understand, and whether or not they're modifiable, give us a sense that around 40% could be attributable to them. But that ain't all that should be considered preventable, in my estimation. And so the central kind of tenet of Cancer Research UK's research strategy is that understanding the mechanisms of disease instigation, progression, and cause is how we're going to unlock better ways to prevent, detect, and treat cancer. So what we're trying to do around prevention research is to support science which will expand our knowledge base of how cancer is caused. And that means understanding the mechanisms of why the things that are epidemiologically linked to cancer actually cause it, or maybe don't. But for example, obesity has been mentioned. We don't have a strong sense of exactly how obesity raises the risk of cancer. If we did, we could be much more targeted in the way that we then try and intercept disease progression. And that philosophy of mechanistic understanding underpinning intervention to prevent cancer applies universally. So you asked about the difference between kind of targeted cancer prevention through drugs or what have you versus behavioural intervention versus policy intervention. Well, actually, it applies to all of them. So you can see how, if perhaps we mechanistically unpick a cancer and we find this mechanism, we can target that with a drug because we found a new target, much like therapeutics development does. But it also applies to, I think, behavioural research. So, for example, if we take obesity again, obesity isn't one thing. There are many different mechanistic strata within it, different types of metabolism, different types of fat type and distribution, different types of metabolic processing. And one person's obesity might respond to a very targeted dietary intervention, and another wouldn't. One might respond to a very targeted exercise intervention, and another wouldn't. So that mechanistic understanding can inform how we intervene across all types. And I think that's crucially important. And then the other thing I wanted to mention about our prevention research strategy, which Susan touched on, is the concept of risk. And that at the moment, preventive intervention in terms of screening, in terms of aspirin, in terms of anastrozole, as Peter was touching on, is informed by a view of cancer risk in the individual. And at the moment, we judge risk relatively crudely. It's usually based on age and family history, by and large. But there's a lot more to cancer risk than that. And we've already touched on things like the socioeconomic factors that affect cancer risk. There's things like environmental pollution that affect cancer risk, your socioeconomic status, your behaviors, your internet search history will tell you something about your risk of cancer. So I think there's a real opportunity for us to get much more sophisticated about how we understand risk and then use that information to better target preventive intervention.
Excellent. So I'm just going to loop round on some of the points that people have brought up, but Francoise Mangan, who is a health economist at NICE, has put a question in the chat, which was something which I had sort of noted down. Ultra-processed food, so big buzzword, Tim Spector, Chris Van Tulloch, so what is the evidence? And is the evidence ready to act on? And if so, should that be individual actions or should it be policy level action? So can I throw that over to you, Kate, to comment upon?
Yeah, thanks, Claire. So I think in terms of ultra-processed foods, we need a lot more evidence. The evidence is not yet sufficiently clear to be able to make those sort of recommendations. Also, there's often a lot of disentangling to be done with high fat, salt and sugar foods, where we know that there is a much stronger evidence base, and we know what the government actions are needed to address those. And so some of our research focusing on that, for example, has looked at online marketing of unhealthy foods to children and younger people, because we know that if children are obese, then they tend to also be obese as adults and to have those health problems that follow on through their life as a result of that. So a lot of the action that we'd like to see from a policy perspective is really targeting the high fat, salt and sugar foods, and particularly marketing to children and young people who are at particular risk of starting a pattern of behaviour that's then very, very difficult to change later on.
Yeah, and I think also just zooming in on those types of questions around diet, there's so much sort of public information out there. It's not just about ultra processed foods. I don't know if what appreciation the public have of what is or isn't ultra processed. Information around microbiomes, information around different types of polyunsaturated fats and so forth. There's evolving evidence. There's soundbitey, headliney, data trawling, finding type evidence. There's fads, there's superfoods. So I'm going to ask Rebecca, how can we give the public some simple messages that they can work with, that they can have agency to manage their own diet without sort of this noise and confusion?
I think you've hit on a real challenge there, Claire. I think we're working against a tide of headlines over the years, which often contradict one another. It's easy to see why the public's confused and doesn't necessarily trust what's being said. I think equally diet is complex. Some of these messages are more difficult. I think that I'm not sure that this focus, as is often the case with headlines, on soul foods or superfoods approach is helpful. And I think thinking more about healthy dietary patterns might be a more useful message. I also think that even when we're not trying to change behavior and are just trying to give information, it's not necessarily helpful to just give information, and combining it with signposting on how people can change and where they can go for support with that is probably going to be more positive from a person's perspective in reading that. Having trusted sources where the information comes from, delivering the information in a supportive and not blaming way. I think you have to be really careful about perpetuating this idea that behaviours are simply down to choice, and particularly for obesity, that's created a lot of stigma, which comes with its own harms. And so I think trying to help the public to understand some of the complex drivers behind our behaviours that are wider than the individual is important, both for reducing stigma and helping to accept some of the policies that Kate's touched on.
So I saw a message in the chat. Do come off mic, David. You summed up the whole field of nutrition is a total mess. Causality matters. There's only so much nagging people will tolerate. Do you want to elaborate on that?
Yes, the question of causality really is critical, and it's almost totally unsolved in this field. There's all sorts of people trying to sell you stuff all over the place, which doesn't help. I mean, I understood from George Davies Smith that 60% of your fate is sheer luck. But if that's the case, then it's probably...
Yep. I think David's paused. He's been censored by the forces of the internet. So we'll come back to him. I was going to, I mean, I think he's probably in agreement that there's complex mixed messaging and confusion. I guess the question is, who could best give some clear, simple messages to the public they can trust? You know, given that no one watches the BBC anymore, who should the public go to? Who should occupy that space as a trusted messenger? Should it be primary care, GPs, social media, charities, so forth? So maybe Kate, can I put that over to you? Francois says he watches the BBC, so that's good. But that's why you're so sensible, Francois. If only everyone did. So Kate, who should be the trusted messages of the 2020s and 2030s?
Thanks, Claire. Yeah, so I think that a number of the parties that you just mentioned have an important role to play. So, of course, health professionals are often in a situation where there is an opportunity to have those conversations, and the Making Every Contact Count programme really sort of recognises that opportunity and provides some tools and resources that health professionals can use to have those conversations with people. We also at Cancer Research UK have a health information team that works really hard to make sure that health information can be provided in ways that is accessible and it's trusted and that it's very accurate. So they have information that helps people to break down what some of the myths are about, for example, particular types of food that may or may not be linked to cancer. There's also a cancer awareness training that health professionals can access, and cancer awareness in the workplace as well when they go out to speak to people in their workplaces. So I think there are a number of potential routes to gain that information, but what is really important is that it's reliable, accurate information. So I would say come to our website, Cancer Research UK, because we know that that's really accurate, high quality information, and speak to health professionals who have that training to be able to provide advice and signposting, and also access those services that are out there to provide that support through the NHS.
So I think it's interesting. You said for people to come to the CRUK website, but when you went out there with obesity health promotion, it was quite controversial. Any comments on that?
Yes, so I think as Becca mentioned, with obesity, it's really important to be very careful around stigma, and the messages that we provide around obesity need to be mindful of that, and think that referring back to some of the points that I made earlier about some of those commercial influences and the environmental influences, people don't have the same opportunities to keep a healthy weight according to where they live, to the environments that they live and work in, the nature of their sort of working patterns, their income, etc., access to transport and so on. There's lots and lots of factors, and people who live in areas with higher levels of deprivation are more likely to be obese or to be overweight.
So I'm going to bounce over to Peter now, actually, on that theme around socioeconomic determinants. You mentioned vaccine hesitancy, that's definitely one, but around HPV more broadly. So Peter, did you have comments on socioeconomic determinants?
Yes, I think it's quite interesting when we come to think about prevention and what we think of as a success. So we normally think about how much disease is there, and then we might prevent a smaller proportion of the disease in a group that is deprived. And so you'd think, actually, we're doing badly in terms of in reducing health inequalities, because screening uptake is slightly less in the more deprived groups. But because the burden of that disease is much more in that group, and because it has much more of an impact in reducing their life expectancy, if what we really care about is the difference in life expectancy, as you were talking about, the beginning 69 or was it 91? I don't remember. But by tackling diseases which are more of a problem in more deprived communities, and that will be the disease which are caused by things such as smoking and obesity and lack of exercise, then actually it is likely that the absolute impact in terms of reducing inequalities in life expectancy and the years of life with comorbidities would be reduced more. So it's interesting because we often worry that actually you're only going to increase health inequalities by doing things. But I think at a real societal level, then things which are tackling the causes of ill health, which are particularly there amongst more deprived groups, would be a good thing.
So I'll come back, I think, to socioeconomic determinants. I'm just going to go to Susan Domchak. So it was mentioned at the beginning, particularly by David Crosby, about risk stratification, identifying high-risk individuals. So maybe, Susan, can you speak a little bit more about identification of high-risk individuals and maybe also surgical prevention in those groups? And then maybe I'll come back to you, Peter, around polygenic approaches, but Susan, sort of high-risk genetic groups. And then Gabriella, I'll come to you. I can see your hand up.
Absolutely. So we have a very much increasing understanding over the last 25 years of genes. When there's pathogenic variants inherited in these genes, there's a very high level of risk. You know, we started with BRCA1 and BRCA2 and Lynch syndrome genes, and that has expanded. So we know more about genes like PALB2, RAD51C and D. So we have an ever increasing understanding of risk of individuals at extremely high risk. With BRCA1 and 2, that lifetime risk of breast cancer is 70%. The lifetime risk of ovarian cancer for BRCA1 up to 45%. In these individuals, surgical prevention can be seen as very important, and particularly oophorectomy, given that we have no effective way of finding ovarian cancer at an early stage. Risk-reducing salpingo oophorectomy is standard of care for individuals with BRCA1 and 2 mutations, and it's really about the age at which we do this. And so we really do have an understanding of those individuals are very high risk. So now we have to make sure that you find them. And so this is where there are disparities also in who gets genetic testing, and is definitely more common in wealthier, white populations. And in the United States, we're really working to reduce that gap and to make sure that all those individuals who are at high risk of having gene mutations get tested. I think the question becomes, who should get tested for these? And I know that this has been an ongoing conversation. Claire is very involved in the UK and in the US as well about whether we should be doing population screening for certain gene mutations. The problem is that there's lots of different genes with lots of different risk. We've already talked about some of the communication challenges, even related to, obesity and diet. Now you take on different genes with different levels of risk. And I think that it's very challenging right now in order to how to do this effectively. In the US, you could make an easy argument for doing BRCA1 and 2 and Lynch syndrome testing on everybody. But the problem is everybody wants to test for 80 genes, many of which we don't know that we're really going to help anybody with. So I think this is there's a real need for better communication, risk-based communication via these various genes. And then I think we'll talk about polygenic risk scores, which is a whole nother can of worms, kettle of fish.
So I'll bounce over to Peter. So your high penetrance susceptibility genes will find a small number of people at very high risk, but there's interest in whether we can use a sort of normally distributed polygenic risk to identify more sort of subtle increases and decreases in cancer risk, plus minus combination with other factors. So Peter, any thoughts on application of that in paradigms of prevention?
Yes, I think I think you need sort of a risk stratified a menu of things that you can do. If you're at really high risk, you might well consider prophylactic surgery. It's pretty extreme, but it generally works extremely well in reducing your risk dramatically. If you're just average risk, you should still aim for a better diet and more exercise and reducing your alcohol intake. But if you're at high risk, then as Susan talked about, there are drugs that you might take, and whether that's aspirin or an aromatase inhibitor or a SERM. But the problem is that those side effects. So if you knew that not only were you at higher risk, but if you also knew that this drug was likely to be working for you in reducing your risk. And so that comes to so that we can have different ways of estimating risk, and you can certainly do that with the polygenic risk score. So you can sort of say, what is the genetic risk? The slight problem with that is that the genetic risk isn't really modifiable as such. And so I think Susan was saying, with cholesterol, if you take a statin, you can see that you've lowered your cholesterol and you've reduced your risk. We don't yet have that really for any drugs for reducing the risk of cancer. But as we get better knowledge, better understanding about what that causal pathway is, and then we're going to be much more likely to say, this drug is working for you. So sort of a precision approach to prevention. I don't know if David wants to come in. I also saw that Gabriella has had a hand.
Yeah, I'm going to jump over to Gabriella and then come to you, David.
Hello, everyone. Good evening. Thank you for this opportunity. So I'm Gabriella. I'm a community support officer for Portuguese and Brazilian residents within Brent Castle, within Brent. And my question is really clearly, the residents who I support are overstayers. Some of them are not registered with GPs, and they are not part of the conversation. I'm a peer researcher for Oxford University with a PhD student, and I've been raising this call. And I would like to understand what type of approach, what type of support are we doing when it comes to these emergent communities who come from different countries we are not involved because they have lack of health literacy. So it's important for us to bring to the table, while producing policies, how can we support and educate, because they are the future, please. Thank you.
Thank you so much, Gabriella. And that, I'll come back to you in a moment, David, but that actually leads very nicely into a question I had jotted down, that there are some interventions around cancer prevention which are very high tech and they're expensive and they're individualized sequencing of your microbiome. And then, as you mentioned, there are very underserved communities. So how do we ensure, as we evolve approaches to cancer prevention, that we don't leave behind these underserved communities and only have interventions that are for the kind of the few who are able to engage and afford them. So I'll pass that to Kate, I think, if you had a comment on that, particularly in reflection of Gabriella's, those communities in particular.
Thanks, Claire, and thanks, Gabriella. I think it's really important to recognise that there are communities that are not receiving the same level of support, and that we need to think about how we target and tailor approaches to the groups that are most at need. We have recently commissioned some research to look at how we can ensure that smoking cessation services are targeted and tailored more effectively to reach communities that need them. I think in terms of the type of support that you are providing, that sounds like it's incredibly valuable in itself, that there's information and support that is being provided by yourself and by your organisation. So I think there are some resources out there that might be helpful to you in terms of some of those techniques and approaches that can be used to help people to understand the connection between smoking, food choices and cancer risk, and alcohol and cancer risk, and also to be able to use some of those techniques like goal setting and monitoring to be able to move from where you are now towards where you would like to be, and to be able to break that down and have some support in a tailored way. I'd be very happy if you wanted to get in touch with me to sort of signpost you to some of those resources that might be particularly important for you.
Excellent, thank you. So David, did you have your hand up? Otherwise, I am going to ask you something else. So either which way, you're on the hotspot.
Okay, well, yeah, I was just going to do some stuff following on from what Peter and Susan were talking about, but ask your question and I'll fold it all
Well, I was
in.
going to, an area we haven't really touched upon is environmental and occupational hazards and pollutants. And do CR UK active in this area? How do they influence policy? What's the direction of travel there?
Well, I can seamlessly segue the whole thing in. So, you know, Peter and Susan were talking about risk and, you know, increasing our understanding of genomic risk. As I mentioned earlier, there are many other types of risk. So you can take out atmospheric pollution as an example. For each of those, the risk is mediated through biology. You know, so just being poor in of itself doesn't automatically cause cancer. You know, that it mediates through an effect on your biology through diet, exercise, obesity, smoking, atmospheric pollution. And each of those are mechanistically unpickable. So if what we can do is to find the mediating pathways and find, you know, the mechanisms by which they're actually causing cancers, those can be targeted in quite a precise way. Now, we're still going to need public health interventions, you know, at a population level. You know, tobacco taxation and the smoking ban in pubs and things like that, you know, did infinitely more for cancer prevention than sort of any sort of targeted, you know, drug-based nicotine replacement therapies. So we need those big population level interventions, but I think there's going to increasingly be an emphasis in the future on really personalized interventions to maintain health as well. So something we haven't touched on yet is the possibility of cancer vaccines. I'm going to tie this back into the pollution thing in a minute, don't worry. So cancer vaccines have been in development for some time as a therapeutic. And a vaccine is based on understanding, you know, the biology of what it is that you're looking for. So with a therapeutic cancer vaccine, you've got a cancer patient and you can look at their cancer cells. You can do some sequencing of the genes that are, you know, driving that cancer and then find antigens and then vaccinate against them. The hope then is that you can translate that into a prevention setting. And if you can understand the biology of the very early disease well enough, hypothetically, you could give someone a vaccine that then, you know, taught their immune system to sort of patrol their body and surveil, you know, very early cancer cells and snuff them out before a cancer has a chance to take hold. And that can be based on germline genomic risk. So there's plenty of research ongoing with things like Lynch syndrome to try and vaccinate against the kind of common manifestations of the risk of that condition into cancer antigens. But that could also be done through the sort of more behavioral risk factors, so smoking, for example. And if you understand the biology of lung cancer patients and you understand what a smoking-derived lung cancer looks like, you may be able to vaccinate against that. Atmospheric pollution, we're beginning to understand more how that drives an increase in risk in lung cancer, but also other cancers. And that's through an interaction with the immune system and the inflammation it causes and how that sort of takes the brakes off early cancer development. So there may well be opportunities for either vaccination or drug-based strategies to intervene in that risk. But it's through understanding the mechanism that we'll be able to do that.
So excellent, thank you. So I think we've only got a couple of minutes left. So unless anyone has any other points, I'm going to hand the mic back to David. Did you want to carry on? You were rudely taken off mic by your internet connection. Are you there? Did you want to finish off?
Yes, new damn computer. Well, I just typed it all out in the chat actually. The trouble is nobody knows why the Marmot effect is so strong, why income is so correlated with health outcomes, because all the other things that are mentioned are all strongly correlated with income: smoking, exercise, diet. They all have systematic differences between different income groups. And this is not terribly helpful, I suppose, because I'm just really all I'm saying is that we don't know the answers to these questions. And as I was saying, I'm not sure when I got cut off, there's only a limited amount of nagging the public will take. If they're being told to go to the gym, there has to be jolly good evidence for it.
Yeah. And how you get them to carry on doing it as well. There's sort of short-term interest, even if someone's attention is captured, but you need decades-long adherence to these preventative measures. And how do we engage people for long enough and keep them engaged in the message and the value of that behaviour change? I think that's very clearly a massive challenge, particularly in an environment where there's so much competition for people's attention and engagement. So I think that's a very major challenge. I was just going to, one of my colleagues at the Marsden did a teachable moment. So it's women who had presented with a breast lump that was then investigated with a normal result. So she took this cohort and was doing education around weight loss, alcohol, exercise and diet. And she was funded to do online expert-led peer support sessions, and just got this very, very disappointing tail off. So this is patients who had had a breast lump and a good news outcome, and who had gone to the Marsden, who are therefore a sort of quite socially biased group in themselves. So actually keeping people's attention after they've had that first sort of good news, and then they're engaged in their health prevention, but getting them to stay with it.